Hello everyone, my name is Hunter Hicks. Today we're going to look at the treatment really of insomnia, and we're also going to look a little bit at restless leg syndrome. Let's get started. So we're just going to start out with the basic physiology of our patients when they sleep. Now we know that our sleep is really broken down into two phases. We have our REM and our non-REM. Now majority of our time is in non-REM. And how we know if our patient's in one or the other, how that works, is they're going to be hooked up to EEG, which is going to look at the brain waveforms. Now, non-REM is really kind of subdivided into N1, N2, N3, and it's different phases your patient's going to go into a kind of a deeper sleep. And now really during non-REM, we know we get a lot of release of growth hormones and less release of things like steroids. Now we kind of bounce in between non-REM and REM, and we kind of stay in one or the other for a certain amount of time. But obviously majority of our time, longer minutes in non-REM, shorter time in minutes in REM. Now in non-REM, and really sleep in general, we know that our patients can drop their heart rate, their blood pressure, their respiratory rate, and they can even drop their temperature about 0.5 degrees Celsius. All that's going to be normal. Now we're in REM sleep, which we know is when we're dreaming. We call that paradoxical sleeping, because really what that means is if you were to put the EEG on an awake patient and then a patient in REM, they really look pretty alike, because in REM sleep we know that's when our dreaming happens and a lot of our emotions are going on. Two patients here that we're going to talk about with way different sleep schedules. So a newborn average sleeps around 16 to 18 hours a day. Other unique things about newborns and our infants is that they go directly into REM sleep. They don't have this non-REM phase, they go right into REM. Outside of that, we know that they spend longer time in REM sleep than our adolescents or adult patients. When we look at the elderly patient, right around maybe the age of 70, we're going to see a lot of issues with their sleep. Now, men usually typically have issues with this earlier than women, but really our elderly patients have trouble falling asleep or staying asleep. Now, obviously, this can happen at much earlier times. Obviously, this can be medication dependent, disease process dependent, and just activities of their daily living or their daily routine is off. But on the average age, if you took all that away, they start to have issues with their sleep in later ages around 70. But obviously, diseases and stuff like that can make issues with sleep even at younger ages. Now let's first talk about what keeps us or what wakes us up before we talk about what puts us to sleep. So we have two big substances or chemicals that are released that wake us up. So we know we have histamine and orexin. Now, why does this matter to you? Well, there are medications that we can give that we know we can block these substances and help our patients sleep longer. Obviously, histamine, like a histamine 2 receptor like Benadryl, is found in a lot of our Z-Quil and NyQuil or other histamine 2 receptors we find in those medications. When we look at orexin, we know we have suvorexin that'll block that orexin and let our patients sleep longer. So what I'm trying to say is these two substances wake us up. Medications exist to block those and help our patients sleep. Now, when we look at the patient that is sleeping, we know a substance that is released that helps them go to bed is our GABA. Now, a class of medications that obviously comes to your mind right away is benzos. That's why some providers give benzos to help our patients fall asleep or stay asleep, because it's working directly on the GABA receptor to help us sleep. Now, when we look at our sleep disorders, we know where we have our dysomnias and our parasomnias. Now, really the difference, dysomnias are patients that have trouble falling asleep or staying asleep. Subset under dysomnias are things like insomnia, restless leg syndrome, and obstructive sleep apnea. All these things cause our patients trouble staying asleep or falling asleep. Parasomnias are really everything but that. These are patients that maybe have trouble while they're sleeping. Parasomnia is more common sometimes in our adolescents or our younger infants, and they're more familial. Now, that's not always the case. We know parasomnias can also be in older adults as well. Now, parasomnias are things like sleepwalking, sleep talking, night terrors, things like sleep paralysis. All those we talk about are parasomnia. Now, when we talk about the treatment of insomnia, we know that one thing we talked about already was blocking histamine, blocking orexin. Then we talked about acting directly on the GABA receptor with benzos. Now next, we're going to talk about drugs that are benzo-like drugs. So these medications, what they're going to do is they're not going to work directly on the GABA receptors like our benzos do, but they're going to enhance the effect of our GABA receptors. So things like that is zolpidem, or a common name, obviously, or generic name is going to be Ambien. Other things like Lunesta. These are kind of these hypnotic drugs that work like benzos, but they don't work directly on the benzo receptor. Now, these are still Schedule 4. They still have risk for abuse, but the thing about them is they're going to have a little bit less risk for that tolerance of abuse because they don't work directly on those GABA receptors. Now, big adverse reactions, big side effects we always worry about with these drugs are things like sleep driving, sleepwalking, sleep talking, sleep shopping. These patients will do these activities and have no recollection of it at all. Now, big thing about Ambien, a lot of times it helps patients fall asleep but maybe not stay asleep, so we know we have an extended release. But a lot of times with any of these drugs we talk about for insomnia is they're only supposed to be prescribed for short term. Now, Lunesta is a little bit different. I think that one you can be a little bit longer, and that's just mostly because from what I found, a lot of the studying was longer, like 6 months and up to a year, whereas the other drugs, it kind of cuts off a little bit earlier. Now, we know a lot of patients are on these drugs a lot longer than 2 to 3 weeks, but that is really what we should be prescribing it for, shorter time. Now, another medication that we can take is melatonin. Now, melatonin we know is released from the pineal gland, and it's going to help really our patients fall asleep. And it's really helping with our circadian rhythm. Now, melatonin's great. You get it over the counter. It's studied heavily for patients that have jet lag. It's a great med for patients that have jet lag. You know, they go on this international flight, they're all off, give them melatonin. Helps out a lot with that. Now, melatonin, not a ton of side effects. Now, it can mess with prolactin, so we want to be careful here if our patients are having any issues like amenorrhea, and we want to be watching that. Now, the other thing about melatonin, like big doses, I'm kind of talking more there with the big doses, but also they can have night terrors or even nightmares sometimes. Roserum is another medication. It's like melatonin, but it only works on the M1 and M2 receptors. Now, those are important because those are really what help, those are the important ones for sleep, basically, where M3, not so much. Now, melatonin works in all three. Roserum may be a little bit more specific for those two receptors. Other medications we know we can give that are even outside this class are other hypnotics or even other antidepressants. So a good one here is trazodone. Now, trazodone is a great medication. Sometimes even better if a patient's on an antidepressant like Wellbutrin or something, and they have this the stimulant effect from it. Trazodone might help kind of offset that a little bit as well. Now, another dysomnia we were going to talk about is restless leg syndrome. Now, restless leg syndrome is going to most commonly occur around year 30 to 40. It's more common in women than men, and it's going to be more common in patients that have an iron deficiency, and it might have an issue with the iron getting across the blood-brain barrier. Now, with restless leg syndrome, it can happen in the legs and even the arms. Your patient will have some degree of this uncomfortable feeling, whatever they might describe it as, and they need to move quickly to get that feeling to go away. Now, obviously, that can cause issues with your patient sleeping because they're constantly having to move. Some common treatments for this would be like gabapentin, your dopamine agonist, same thing we use for Parkinson's. So things like Requip is one we can use. Now, be careful again with our dopamine agonist. We know that that can cause our patients to be tired and cause orthostatic hypotension as well. Another thing sometimes that can be done is even iron supplements for these patients. In general, when we're looking at treating insomnia, we always want to use non-pharmacological treatment first. We know this, but when we're doing the medication, the pharmacology, we try and make it shorter duration. Now, if patients are coming back and they're constantly needing more medications, that could possibly be more tolerance rather than they're not, that their insomnia is not getting worse. They might just be getting more tolerance to the medication. So something we want to keep in mind when prescribing these medications. Hope you guys like this video. Again, this is not medical advice, just a great way to study. If you guys have any questions, please leave them in the comments. Give me a like, and we'll see you next time.